Hello and welcome to the State Peer-to-Peer Learning Session, Facilitating Care Across the Crisis Continuum Using Technology and Data. Please note this meeting is being recorded. All participants are currently muted. You may submit questions and comments into the chat box throughout the meeting. We encourage you to view the meeting in speaker view to easily view the presenter by changing your view in the top right-hand corner of your screen. Closed captions can be accessed during the meeting by clicking on the closed caption icon at the bottom of your screen. And I will now turn the call over to today's moderator, Ted Letterman. Please go ahead.
Hi, everyone. Thank you for joining us today. I'm Ted Letterman with the Nashville Research Institute, and I'm pleased to introduce Mr. Thiessen Thomas, who is the Deputy Director of the Center for Mental Health Services. In this role, he provides leadership for federal efforts to improve the nation's mental health service systems. Mr. Thomas is also the director of the State and Community Systems Development Branch of SAMHSA, which includes overseeing the Mental Health Block Grant. So with that, I will turn it over to Mr. Thomas for some comments from SAMHSA.
Thank you, Ted, and much appreciate the introduction. Good afternoon, everyone. So on behalf of SAMHSA, I want to take a moment to thank everyone for joining today, and especially thank our presenters from both Georgia and Oklahoma. SAMHSA, as you know, is committed to partnership with states to improve the response to behavioral health crisis. Today's session is one part of this effort. The state peer-to-peer learning session will focus on the important issue of sharing information about individuals experiencing crisis between crisis system providers to improve care and allow monitoring of how well the crisis system is working. Many of us have heard how challenging it can be for individuals experiencing a crisis to be required to repeat their history and current situation to multiple providers when experiencing crisis. A person in the midst of a crisis may need to share information with a crisis contact center, such as 988, repeat that same information to a mobile crisis team member, and potentially repeat it again at a crisis receiving or crisis stabilization program or in an emergency department. Information exchange and coordination between crisis providers and other community-based supporters can help improve the crisis response and reduce the burden on individuals to repeat previously shared information. For instance, a mobile crisis responder will be far better prepared to engage, support, and assist an individual in crisis when they have access to the information already shared with a crisis contact center. So this session will focus on how two of our states, Georgia and Oklahoma, are sharing information between components of their crisis continuum, and they ensure vital information is conveyed and this decreases the number of questions being asked for individuals as they move between different crisis components. We are very excited about this because we see the CCBHCs, the Certified Community Behavioral Health Clinics, as one of our flagship programs. And it is a strong model that we believe has the ability to reshape the community mental health center landscape. This includes crisis components that are embedded in the CCBHC model. So our two states, Georgia and Oklahoma, will provide information on what is exchanged between crisis system components to facilitate a high quality care, what kind of data sharing agreements or requirements states have established to facilitate this information exchange. And lastly, how the information is being shared in real time between a crisis contact and a mobile crisis responder, for example. So having the ability to share information between crisis system components can also empower state and local agencies to better monitor how well their crisis continuum is working. States can use this information to identify gaps or shortages between crisis system components. So our two states presenting today have developed different approaches to address the issue of sharing information between components of crisis system. So after the two states present their systems, there will be time for other states all of you to ask questions to share how their state systems address the issues of sharing and tracking information across their crisis service continuum. So I want to appreciate and thank both Georgia and Oklahoma for taking time to do this. And also thank all of you for joining us in today's session. Thanks, everyone, and back to you, Ted.
Thank you, Mr. Thomas. So I'm going to introduce the speakers from both states, and then Oklahoma will go first and be followed by the two speakers from Georgia. There's a disclaimer slide here about the opinions are the people from the states. They're not SAMHSA's opinions or official policy. Speaking from Oklahoma, Carrie Slayton Hodges is the commissioner of the Oklahoma Department of Mental Health and Substance Abuse Services. In this role, Carrie helps ensure that addressing mental health and substance use issues remain a top priority for all Oklahomans. During her tenure at the agency, she's led the charge to create a system that set a national standard for prevention, treatment, and recovery for those impacted by mental illnesses and addiction. Carrie prioritizes services designed to address the needs of high-risk populations and continuously enhances a continuum of community-based services across the entire state. Under her leadership, Oklahoma is regarded as an industry innovator and is leading the nation's launch of 988 Mental Health Lifeline, creating the most comprehensive crisis response continuum in the nation that leverages technology and alternatives to law enforcement involvement. Wendy White-Tygreen is the Director of Medicaid and Health Systems Innovation for the Georgia Department of Behavioral Health and Developmental Disabilities. Wendy has almost 30 years of experience working in service delivery and administration in the public behavioral health sector. The majority of her career has been spent as a liaison to the state Medicaid Authority. In that role, she was the primary negotiator with the Centers for Medicare and Medicaid Services in the establishment of peer supports as a Medicaid financed service. And she's a presenter at several national Medicaid health and behavioral health management conferences. And Dawn Peel is the director of the Office of Crisis Coordination for the Georgia Department of Behavioral Health and Developmental Disabilities. She's worked in the behavioral health field for over 26 years with diverse roles in the public, private, and nonprofit sectors. Dawn's worked for the Georgia Department for 12 years and currently serves as their director of the Office of Crisis Coordination. She's responsible for enterprise oversight of their state-funded crisis system and collaborating with internal and external partners for the implementation of 988. With that, I'm going to turn it over to Dr. Slayton Hodges to talk about Oklahoma's work on using data to drive crisis services.
Thank you, Ted, and thanks to all of you who are here today joining us. If we can go to the first slide, please. So just a little bit of a layout of Oklahoma. We are a statewide CCBHC state. So our state is broken out into regions. Each one has a safety net provider that is a CCBHC. And that's important as we talk about the different elements of the crisis continuum, because our CCBHC system is the backbone of our crisis continuum. We are a PPS2 model, which means that the payments are per person monthly. And although we have been a demonstration state and a state plan amendment state, we currently are now all back as a demonstration state, as that opportunity has been brought to bear. So next slide, please. So you can see kind of how our state is laid out in terms of CCBHC regions. Again, this is somewhat important because each region is responsible for a host of crisis elements within their region. And so we work with them to ensure that we have a full continuum in each of these CCBHC regions around crisis care and aftercare and continued care. And so we leverage our partnership with these networks to have a full continuum of care across our state for the crisis system and in terms of collection and dissemination of data. So next slide, please. So this is what our crisis continuum of care looks like. And as I talk through this, each one of these components has a large data collection component with it that then blends all together to give us a full picture of what is happening in crisis around the state overall for system improvement and gaps, but also even down to individual persons who we are seeing in crisis frequently and who we may need to work with to develop different types of care and or different discharge plans from our crisis system. So it's really important. And I'm going to start with number one, and that is, just like most states, we have a 988 system in our state that we have built the system around. And we have one call center in our state that when you dial 988, all calls go to. And we use that system to collect and disseminate a great deal of information that you'll see some bits of as we go along. But, and of course, that we have data sharing agreements with our 988 call center, who is run by Solari, with our CCBHC network, and of course with us, as they are a contracted entity for the state of Oklahoma to run this call center line. The next component that you see is mobile crisis teams, which we have set up a system to where we have statewide mobile crisis capability. And one of the things that is interesting when you look from the 988 system to the mobile crisis team system is that the 988 call center dispatches the mobile crisis teams, which are embedded within the CCBHC networks within their region. And so when our 988 call center takes a call and has worked through that call to the point where it is deemed most appropriate for a mobile crisis team to dispatch, then that happens through a system by which the mobile crisis team then now is populated with the information that the call center has gathered about what is going on, everything that they have talked about, what kind of risk elements are there, etc. So that is dispatched out to the mobile crisis team, who then goes out to that call, but continues that loop, that feedback loop to the call center about when they're en route, when they have arrived, what they have encountered, what has been seen, etc. Now, one of the nice things about having those mobile crisis teams being dispatched in their region from the CCBHC is that then that just continues to blend itself through the rest of the continuum of care. I'll continue on through the continuum of care so you can see how these flow together. Now, one of the other things that happens here, you'll see follow-up appointments. So if the call center is making an appointment with one of the CCBHCs in its area, then that information can seamlessly pass along between the CCBHC and the person and the call center. So that information, again, doesn't have to be repeated. The person knows where they're going. The CCBHC is ready and waiting for that person, and that kind of connects those dots. When you look at number 4, you'll see something that says integrated technology. And one of the reasons that that is important in our system is we use, you may have heard before, we use a great deal of tablets across our state, and we use those in a number of ways. One is that all law enforcement vehicles across our state have a tablet in their vehicle that connects directly with a mental health professional that links to that CCBHC in the region that law enforcement is at. So if law enforcement comes across a person in the field that they feel like is struggling due to a mental health or addiction issue, they can use that tablet, push a button, connect right to that community's mental health crisis system. And when that happens, then there's a number of things that can happen. They can send a mobile crisis team out, or they can do an evaluation and assessment right there on the tablet. They can direct them to where to bring the person, or they can set up an appointment for the next day and let law enforcement know that this situation is fine, you're good to leave, and we've got it from here. And this is important as well because behind the scenes of that technology, we collect a wealth of data. We know where that call originated from, who it went to, the length of time, how long it took to answer. All of those sorts of technical data elements we're collecting behind the scenes there. Then when you get to the next bullet, that is transportation. So in Oklahoma, as part of our crisis continuum of care, we, through our community partners, do all the transportation when law enforcement used to do transportation. So when a person needs to go to a higher level of care or an evaluation, we're going to do that transport. And we keep data around those transportation elements too, and we'll see a little bit of that information. And so as I point out each one of these elements, all of these link behind the scenes together. So we can track a person through this crisis system to see what is happening. We can also see how well each of these pieces are working and coordinating with each other and where gaps may occur. Now, when you go on to facilities, we have a system throughout Oklahoma where we have urgent recovery centers and crisis units throughout the state. We can also then follow that person into these locations, share that information, and then follow them through that discharge and back out into community-based services, and then hopefully not follow them back into crisis again, but if they do, we can follow that element. So what I'm going to show you in the next series of slides are just slices and dices of those elements of data that you can look at and means that you can use it just to kind of improve your system. So if you'll go on to the next slide, we'll start to look at some of those data elements that are collected. So this one first would be through 988, just kind of some data elements around that help us do continuous performance improvement with our system. So if you'll go on to the next slide. So this is just keeping track of how many dispatch mobile crisis teams are coming out of the system on any given time. How many of those got resolved before the situation got there, and then how many were in grand total. So you can see from January 2023 to November 2023, we had 3,100 basically calls for mobile crisis that were dispatched out across our system. Next slide, please. You can see just through this graph that there has been a steady increase in the use of mobile crisis from kind of beginning all the way up. And again, these aren't calls to 988. These were calls that ended in a dispatch of a mobile crisis. And you can just kind of plot that rise. The big drop off at the end you see was just at the end of this where not all the data was in for that week. Next slide, please. And, you know, one of the things that's interesting, especially as you develop mobile crisis teams and capacity and saturation, is you can plot these by looking at what time of the day are they most likely to occur? What days of the week are they most likely to occur? And that just kind of helps us, especially early on, when we were determining where to place mobile crisis teams, how many to place in a given area, in order to ensure that we have a response time that meets our goals and our criteria. So this is just an example of some of the things you could plot from that. Next slide, please. And then this also looks at age group calls and then plots those by group and week, etc. So you can see the vast majority of calls coming in that are dispatched in mobile crisis are adult, but there are quite a number of youth and child, but that also helps us to determine what our capacity needs are at any given time. Next slide. So then when you look at our tablet use and what that looks like around the state, and we keep data on the back end of all the use of tablets, we'll look at just some ways, some of the information that that provides and ways that you can use that. So if you go to the next slide, we'll look at some of that. So this is just showing you kind of the number of calls coming in through tablets across the state. And you can see on one, it's 100,000. And these are broken out by two. One is a general iPad, and then one you see they call it Senate Bill 7. And Senate Bill 7 was what funded law enforcement calls. Now we put iPads, we utilize iPads in a lot of different ways. So we have, we place them in hospital systems, we place them at health departments, anywhere where someone might need to have a face-to-face with a clinician in a rapid period of time. We even have them, say, for example, with our in courthouses or at our Capitol with our Capitol security. But then also we put them in the hands of persons served so that they can contact a person anytime they want 24/7. So in reality, that's part of our crisis continuum of care, but it's not the crisis continuum of care that people are thinking of when they think of 988 and that continuum of care. These are people that we're serving, that we can place a mean in their hands to have someone to talk to 24/7 from the location that they are receiving treatment services. And you can see that the vast majority of calls are actually through that, which is really what we want. We want people connected to care and to receive their care from people who they know. So next slide, please. This just shows us kind of by agency, the number of calls, what type of call it came in by agency to really help us judge who's using what, where it's most used, etc. Next slide, please. And then again, this gives us some information about time of day. When is this most used and what days of the week, so that we can make sure that staffing levels and capacity are always where they're needed to be and put to their very best use. Next slide, please. And this is just plotting it out by time of day, by agency, again, to give us the biggest and best picture we can have. Next slide. So now when we talk about crisis units and urgent recovery centers, we collect all the way down to client level data that is telling us who's there, why they're there, lengths of stay, all of that information, which we can process in any number of ways. But when you're looking at kind of a crisis system and trying to get a picture of that, these are some of the elements that you could look at to get an idea of that. So next slide, please. So this is just showing our state by county and where people are being admitted into urgent recovery centers and crisis units, where they're coming from. And obviously that really helps us because as a state, we have been growing the number of urgent recovery centers around the state and also the number of crisis units around the state. So it helps us to know each time, where do we want to put another? Where do we need a crisis unit? And that's really just always tracking where people are most using the service. Next slide. And then just kind of gives us a glimpse of over time what we're seeing when we're seeing the admits and use of urgent recovery centers and crisis units, and then also mobile crisis. So we can just kind of put them all together and look at what is most highly utilized, what's trending upward, downward, etc. Next slide. And then we go to our transportation system and we collect a lot of data around our transports as well. And so these are just some elements that we use to kind of look at the system, to do performance improvement with the system that we kind of look at. So next slide, please. So this was just plotting the number of trips that have been done. And as you can see, we started in November 2022 and we did 412 trips. And then you can see that now we're up, and you can see this was October data and it wasn't all in, but we're up around 1,000 trips a month that we're doing, with a total of 10,000 at October 2024 since we started this program. Next slide. One of the things that happens is you request a transport through a portal, and that portal asks you some questions up front that the requester needs to populate. And so, number one, we're not going to go out on the road to do a transport unless we know a treatment bed has been confirmed. So you can see, yes, those are being confirmed. We ask about history of violence. Has there been any physical restraint use in the last 24 hours? Are they meeting emergency detention criteria? Has there been violence during the encounter? Have they received emergency medications, and are they at risk of elopement? So these are all the things that we want to know when someone's requesting a ride so that we can best handle that transport in the most efficient way. And this just kind of shows you the breakdown of what that's looked like over the last year and a half. Next slide, please. And then this one is interesting. This actually is an example of where looking at data has led to policy change. So this was just plotting how many of these trips have been over 300 miles and where did they originate and where were they going? So in looking at this slice of data, one of the things that we knew is we don't want trips of this kind of length. And they shouldn't be happening because we have resources closer, but nevertheless, this is what the requested transports were. So this led to a policy change that was passed last legislative session. Yes, that went into effect November 1st, that says we will transport to the closest appropriate facility. Because we were getting, say, an example, a private hospital system that would want a person transported within their network to their own private hospital system that might be 300 miles away, when there might be a place across the street that person could receive the care that they needed. And so we changed that statutorily so that you don't see these anymore. But by being able to see this helped us realize, oh, here's an area we need a policy change. So next slide, please. So just a couple of other things that I want to talk about that we have used data by being able to look at data across the system that has been important to us. So for example, from our 988 call center, they can identify people who are frequent callers, who are calling a lot of the time. So it's meaning that we are not doing a sufficient job system-wise of meeting that person's needs. And so they are using a emergency line to have their needs met. So we're able to then send that information to the provider safety net in that area to say, there is a person in your area that is a frequent caller, and this would be a good opportunity for outreach to engage this person in care to diminish their need to use emergency services. Another thing that we use is what we call our most in need list. And this has been really important for care and well-being across our state. So we are able to collect data behind the scenes and see people who have been inpatient frequently and for whatever number of days, also in crisis units, in urgent recovery centers, and substance abuse residential treatment facilities. And then we take that person, we do the number of admissions to those and the number of days to those, and then we populate that by a most in need list. So the one with the highest number of days would be number one in the state, number one most in need, and then that would just kind of fall down. At one point in time, we called it top 100 because we really focused on the top 100, but really we call it most in need now. So there's a couple of things that does. Number one, if someone is on the most in need list, it's an automatic authorization for intensive level of services. Pretty much do whatever you need, and we're going to make sure you're compensated for that. But it also allows us to flag when that person has touched our system, alert folks to say, this person is touching our system, And when we do that, we look at what has happened with previous discharges and start to think outside of the box. Okay, what could have caused this person to not be successful in the community during their last discharges? Maybe there wasn't sufficient resources around getting this person directly into housing. Maybe this person needs someone to come out each day to ensure that they are getting the help that they need. But by doing this, we're able to see who in our state is most in need. We also know that these folks have a high concentration of resources being allocated to them right now, and we could reallocate those resources in any number of ways to help that person get into recovery, because that is not what we're achieving right now by virtue of them being in that high populated list. We also are able to identify what are the characteristics of people that are most in need in our state. And the things that we have found is they are persons with a psychotic disorder, a co-occurring substance use disorder, and often are homeless. And that trifecta is going to cause that person to utilize services in the highest way. And so we really try to think outside of the box for those people. So if you'll go on to the next slide, this is actually a terrible slide, but this is just an example where it will show a person how many days they've had in a crisis unit, how many crisis unit events, how many ER visits, how many ER days, how many inpatient days, and it will pull that all together and populate, hey, this is a really high need person in our system that we need to think outside of the box on and do a lot of outreach with. Well, it'll also have kind of the last known places that they've lived, so to help with outreach around these situations. Next slide, please. Oh, so those are just some examples of how we're able to kind of mix and match a lot of this data, and really with a goal of making sure that we build a system that is meeting the needs of people that we serve, and that also that we're having capacity where capacity is needed. And so those are just some examples from how we use data in our state around our crisis continuum of care to continually improve the services we're providing. And with that, I am going to turn it over to our friends from Georgia.
Good afternoon, and thank you, Dr. Sutton-Hodges. That was very informative. My name is Dawn Peel, and I'm going to share this time with you with my colleague, Wendy White-Tigreen, and we're going to talk a little bit about how crisis data is shared within our state. Next slide, please. So CVHGD has a contract with Carolina Behavioral Health to provide administrative services, to serve as an administrative services organization for the state of Georgia. Our ASO is comprised of three main entities. Carolina Behavioral Health provides authorization for services and is also linked to the Medicaid management system in Georgia to identify when people are Medicaid beneficiaries. We also have Behavioral Health linked as part of this umbrella. They operate the Georgia Crisis and Access Line, and they also administer our air traffic control system, which helps us manage our state-funded crisis system. And then Corlent is another agency that is under the umbrella, and they provide quality management services for providers in our network who serve individuals with intellectual and developmental disabilities. So the nature of this organization under the umbrella that it's captured with promotes information exchange among the different entities and allows greater ease of access for that information among our provider network, any individuals that use Georgia's crisis, state-funded crisis system. Next slide, please. So in Georgia, we have what we call a preferred or single point of access into our crisis system. As I mentioned, Behavioral Health Link oversees the Georgia Crisis and Access Line, or GCAL, as we call it. And BHL also is our 90-day call center in the state of Georgia. So like any 90-day call center, they take crisis calls, they do rapid assessment, de-escalation, triage, and referral. But because our system also has the air traffic control feature, the call takers at the Georgia Crisis and Access Line can make referrals to our mobile crisis teams, which, like our colleagues in Oklahoma, are available statewide. They can also make referrals to our crisis stabilization units or our 24/7 walk-in behavioral health crisis centers through this air traffic control platform. And in addition to having options for people to call in to our system through the Georgia Crisis and Access Line, we've also created online portals that can be used by emergency departments or jails to submit our pre-admission referral forms, which are the forms that help us get the information that we need to our crisis service centers, our crisis stabilization units, and our behavioral health crisis centers. Next slide, please. So we use a lot of different data elements to share and track referral information. And I'm going to take you on a little journey, a little history lesson for a moment about how we got where we are. So DVHD began partnering with BHL or Behavioral Health Link to build our first crisis board over 10 years ago. And over time, as our system evolved, we realized that we needed to have our air traffic control system evolve along with it. So over time, we have been building onto the existing system. And what you might know about technology is that when you're building on existing networks, sometimes it can cause glitches. So we've been working with Behavioral Health Link over the past year, unveil a newer integrated system that allows better integration and is more of a seamless application for those that are using the system. Again, our new system integrates all of the facets of our state-funded crisis system, and more so, information can be shared across the system. As Dr. Slatton-Hodges mentioned, our referral information can be shared from the call center staff to our mobile crisis teams as referrals are made, and also back to our behavioral health crisis centers or our crisis stabilization units. Similarly, if a mobile crisis team is dispatched, they can then upload supporting documentation if the individual needs a higher level of care, such as a crisis stabilization unit. One of the things that we find to be particularly helpful is that our pre-admission referral forms are pre-populated with a great deal of information, information about the individuals presenting challenges, as well as any other types of information that might be needed to help the crisis units determine whether or not that person is appropriate for their level of care. Specifically, when referrals are coming from hospitals, like emergency departments, we have medical information embedded into our pre-admission referral form, which makes sure that the individual is medically appropriate for our units. Like many crisis units, our units are standalone, and so they're not normally connected to a primary care hospital that could service an individual that has acute medical needs. And so when a staff member from the emergency room fills out the pre-admission referral form, if the person's experiencing a medical emergency or a medical condition that exceeds the capacity for our units, then the hospital is given an opportunity to stabilize that person's medical condition before a referral is made. Another really helpful feature for our referral system is that our referral sources can upload supporting documentation. And that's really important because oftentimes that will decrease the back and forth phone calls between our crisis units and the referral sources and can expedite placement. There are some real benefits to having these services in place and all of the information in one centralized location. To Dr. Hodges' point, we can collect a great deal of data about the types of individuals that are being referred, the reasons that they're being referred, and then where they end up in our system. That has certainly helped us a great deal as we're planning for how our system needs to evolve with the ongoing implementation of 988, especially as we anticipate increased volume with mass marketing. But there are other benefits to this as well. Years ago, staff from the referral sources were faxing information to the units within their coverage area. And as you can imagine, that's rather time consuming for the referral sources and for the people receiving the referrals. What we've seen with our mobile crisis referral system is that a centralized mobile crisis referral system leads to shorter response times because there's not multiple phone calls going back and forth to get a mobile crisis team dispatched. Again, all of the referral information is in one place. So if someone were to call back the call center about an individual, the call center can pull up the information. And as state administrators, our agency has real-time information to that referral information as well, or real-time access to that. So if there's a glitch or someone calls, we can provide good customer service to the people that we're working with. And 9 times out of 10, if there is a challenge, our staff can work very quickly to get that situation resolved, to make sure that the individual gets what they need as quickly as possible, and the referral sources are getting good customer service as well. So at this point, I'm going to turn it over to Wendy White-Tygreen to talk more about Georgia system. Thank you.
Next slide, please. Hello, everyone. We're so glad to be with you today. Dawn, just as an FYI, I began a response to one of the chats in there, and you can pick up from where I was leaving off. One of the things that we wanted to talk about is the work that we had to undertake in the building of the infrastructure that Dawn was talking about. So I think we want to acknowledge that these partnerships and relationships, the way the ASO works and has kind of 3 corporate entities built together under its umbrella, and the way we relate with our providers and the like, is largely based on that procurement, which was designed in the mid-teens. So it was designed well in advance of 988, blessedly. But it required a lot of legal research from the DBHUD team. And so I think we wanted to get back to the root of what Georgia had to do in order to create all of this, and to acknowledge there are federal laws, there are state laws, and then there are like contracts and systems analyses that had to be undertaken systemically in the initial launch of the Administrative Services Organization, which was inclusive of the Georgia Crisis and Access Line call center. So we undertook this analysis because we built into that contract that we wanted extensive care coordination, which also included the kind of air traffic control systems and notification systems that Dawn was talking about. So what we began to do was to go through and look at all of the federal law analysis related to HIPAA and 42 CFR, and medical law that was very specific to crisis. So I've just got kind of in the cursive font, like key phrases from these laws that then ended up being influencing in our analysis, right? So all of us, we share the same federal law, right? But there's like language about that a prudent lay person, if they define something as an emergency, right? Like, we're not saying that there's a medical doctor saying this situation is an emergency. If a prudent layperson, that's the language, defines something as an emergency, then it can be classified as an emergency situation. And then there is law then that articulates the type of communication that happens in that emergency situation. So for us, as all of us are talking about crisis and crisis intervention around the country, right, then paying attention to those federal parameters has to be kind of the key and fundamental basis for all of this communication that we're talking about. In those federal laws, it talks about that in those cases, like you don't have to like check insurance for somebody. You can feel free to call and like give people's names if it's a crisis. You know, the ambulance can communicate with the emergency department on behalf of that person. So all of those things then are allowed when there's a crisis situation, right? So, and that's the zone of what we're talking about. Secondarily, we can't rely on each other's law, right? Each of us has law or state regulation, which then is also a second layer to how we do information exchange in crises. And so again, like Georgia's law doesn't quite use the same language, that doesn't use the prudent layperson. It uses this language: if this is a bona fide medical emergency, then any medical party that is engaged in the mitigation of that medical emergency situation can communicate to the end of then moving from that being an emergency to the emergency being stabilized. So we had to go through the state statute, and just like many other states, just like at the federal level, we have addiction policy, we have mental health policy, and I will just clue you all in. You also have to be mindful about what are the parental rights and the parental permissions related to children. So all of us are doing kind of whole age responses, so be mindful of that. Georgia actually had some unique laws about situations where someone who is a minor, the permissions and the granting of permissions and releases from parents. And then when that in an emergency situation, that's disregarded. So then we moved through and did the state analysis. And then we moved through kind of the contracts and systems analyses. So in the ASO, like there are arrangements and agreements that it is a joint paid venture of the Medicaid agency and the behavioral health agency, which means we have Medicaid data that is part of the ASO system. That's all governed by memorandums of agreement between the two agencies, which then kind of sweeps in kind of the business associate agreements and those permissions and the covered entity analyses that we had to do. And then, of course, there are laws about our involuntary orders in the state of Georgia, which then allow communication to happen with other parties, for instance, like judges and law enforcement, that had to be taken into account. So there is no formula that we can say, A plus B always equals C, but I think all of us have the same A, and many of us have a variety of B, C, D's, E's, F's, and G's that go into that second formula, the state analysis and state regulation. And then these agreements are, of course, a different dynamic, but together, when a state looks at these things, you can begin to craft kind of how this communication can happen, where it can be done without releases, where it can be done without formal signature, where it can be done without parental permission, where it can be done without, HIPAA privacy signature types of things. And so this is just a slide to just share about kind of the fundamental work that had to be done at the onset to get the system to where Dawn was kind of sharing that we do all this air traffic control and moving about because we do so on a foundation of analysis that was completed, which includes this information here. Next slide. So this is kind of what that analysis looks like for Georgia. And you heard Dawn reference at least once that we also do mobile crisis intervention and use GCAL 988 in Georgia, also for intellectual developmental disabilities, autism, spectrum concerns and crises as well. So we did the analysis for all of the different types of potential individuals who would be beneficiaries of the service. And you see kind of what our outcome analysis here was, with the core communications kind of being in that purple, and then all the different coordinating entities who would be permitted in or permitted or that you don't see, and then little boxes with caveats if there were legal caveats related to those. Next slide. And then one of the very interesting things that we are doing related to technology, and I think it's just kind of important to note is, and I think as we all get more involved with third-party payers and starting to understand this, we wanted to just bring today just at least a brief graphic representation of how we work with our Medicaid care management organizations that do managed care for the CHIP and low-income Medicaid populations in Georgia. And so while we always say that we are insurance agnostic at the call center level and at the mobile crisis response level, so when that person at the top needs to have the green, a mobile crisis dispatch, we're not asking about insurance at any of those points in time. In Georgia, though, once there's a disposition and information flows back to the Georgia Crisis and Access Line, they are, as best as they can, doing some matching of data and information. So whereas Wendy Tigreen might be covered by CMO1 in Georgia, we have 3 Medicaid managed care entities. So I might be covered by CMO1. That disposition is sent to CMO1, and that then allows for the post-crisis care coordination to begin to kick in. So we will have done everything in our power to move that individual to stabilization, but we want the managed care companies to know with immediacy how to begin to kick in and be doing aggressive care coordination, which happens outside of our system. And I mean, in the long run, right, like 2 years from now, 3 years from now, sooner if possible, we would love to rely on our multi-state learnings about how this type of coordination with other third-party payers can begin to become more comprehensive and to begin to be sure that we have the insurance industry, in accordance with parity, really begin to pick up and start to understand the obligations of treatment and support for individuals who may be in crisis. So for now, Georgia has advanced on this for the Medicaid public sector managed care entities, and we continue to hope that we will have additional information and good premises upon which to build in the future. And next slide, I think that may be the last one. Okay, so I'm going to kick it back to the team for the facilitation of questions.
Well, let me thank both our presenter in states, Oklahoma and Georgia. It's terrific work that you guys are doing, and I think it sort of models what we hope the systems can move to, because I have heard several states and people have gone through crisis services, just sort of the comment about how disjointed it can be, where they have to answer the same questions to a call center, to mobile crisis, to crisis stabilization, and that sometimes their fear is that people may give up and not stick with the services if they keep having to repeat stuff. Commissioner Hodges, there were several questions about the transportation initiative, and you might go back and talk a little bit more about how you set up this innovative system to take law enforcement out of the business of transporting people handcuffed in a police car to get services.
Well, we had a number of kind of meetings of law enforcement and the public that were held by a particular legislature in our state. And it was really interesting because that legislator was motivated by a couple of things. One, he law enforcement and public safety was incredibly important to him. And so he really wanted to be able to support law enforcement in our state and take some of the burden off of them. But interestingly enough, he had also had a grandmother who at one point in time had been put in the back of a police car and taken for mental health care. And it broke the hearts of all of the family that was involved in that situation. And so he had a commitment in the back of his mind that he hoped to have never have to see that happen to anyone again. So one of the number one things that law enforcement in our state said was that they were spending so much time around transporting persons with mental illness that it was keeping them off the streets of doing their safety and security, especially in small communities. So the legislature passed a bill that said that if a transport for the means of seeking treatment for mental health and addiction issues was greater than 30 miles, that now the Department of Mental Health and Substance Abuse Services would do it. So that was passed in July to go in effect in November. And so we said, well, we better figure this out. So we did. We partnered with treatment providers as well as transport providers. We kind of set up what those rules would look like and how it would take place and put that into effect. And that was a year ago, last November. And during that year, we transported over 1 million miles around the state. And everybody was pleased with it. The persons being transported were pleased, law enforcement was pleased, legislators were pleased, et cetera. So then this past year, it was voted that not over 30 miles, that now any transports would fall to the Department of Mental Health. And so again, we put that into place. You request it via a portal, and then that goes out to the transporting entities. And it has just worked beautifully. It was not nearly as difficult as we anticipated it being. And I think part of that had to do with everybody was so rooting for this to work that in the initial bumps, everybody gave grace and we were able to put it into place. But it really has been life-changing for both persons receiving care and law enforcement as well.
Thank you. I think in DC, there is a specific question about people with involuntary transport versus voluntary. In Oklahoma, you're taking everybody, including forensics and civil voluntary and involuntary, or are there restrictions?
No, the bill that passed said when law enforcement would normally transport. So law enforcement would not normally transport a voluntary patient. So that didn't fall to us. Now, what we have seen as a result of it, as folks are able to do transport and have a system, we see a lot of entities that contract with them to do voluntary transport. And so we have a tremendous amount of voluntary transport that is being done, but it is really actually paid for by the provider entities to do that now that they have a means that's in place for it to be done. And so we see a lot of voluntary, but it really is a replacement for law enforcement, and law enforcement was never required to do voluntary transport.
Great. There's a question about how your crisis system coordinates with 911 and handoffs on that, and does information shift between those systems, or how is that working? I don't know if either or both states want to comment on where you're at on that.
I'll start and then hopefully y'all have more information to share. I think this is kind of a nationwide challenge in that if you've seen one 911 system, you've seen 911 system, and across states, there are so many different answering entities involved in that. So we have done a lot of work with our Metro Oklahoma City 911 system and have kind of coordinated plans in place for how that will go back and forth, et cetera. And then that's one 911 platform. And then, every town, every sheriff's department has their own. There is a lot of work that is going on a national level. In fact, there was some information that just came out that gave guidelines to these 911 centers, because there's a lot of misconceptions on their part about what they can do, what they can't do. Can they transfer a call? Can they never transfer a call? And that's starting to be helpful as there's more national guidelines for them around how that can work. But right now we're doing it on a case-by-case basis, and it looks a number of different ways. It looks like us implanting staff in 911. It looks on having a back line that is a transfer line. So there's a lot of different things, but it is different almost for each 911 answer system. And I hope y'all have gotten even further and have some great strides there.
Sure. I can jump in and give some background information. So we've had working relationships with our 911 centers, even pre-988, where we could warm transfer people over if there was an active rescue needed. And then with the advent of 988, like Oklahoma, we put up a back line or a dedicated line in for our 911 call centers. Georgia was very fortunate to be a part of a policy academy with the SAMHSA Gaines Center that was specifically focused on 911 and 988 interactions. So we worked very closely with our partners in 911 and were able to create a script that we provided to the 911 centers. Now, what I'll say is, like Oklahoma's challenges is that some of the centers always use it, and some centers are very hesitant to use it. There are a lot of questions about liability that tend to come up about, if we transfer someone to 988 and something happens, is there liability on the part of the 911 center or the operator themselves? But we're working very closely with the 911 directors and the agency that has some oversight of the center statewide to put together some on-demand training. Because what we've learned is that the 911 operators are very knowledgeable about a lot of different things, but don't know the right question to ask, even to determine if it's a behavioral health crisis or not. And so we're putting together training on that, and then some protocols, some flow charts, or if that's what you want to call it, to kind of help them determine what is the next best step, as well as address those liability questions. So I'll pause, Wendy, if you want to add anything else. I don't want to dominate it.
No, I mean, I think you're working so much more closely with them directly than I am, Dawn, but I just want to say it's, Commissioner, it's a challenge, right? When we have so many 911 centers and they are all radically different, from Fulton County to some of our tiniest rural counties where there's just one tech on per shift. And so it's just the diversity of all of the entities we're working on, and our association has been an amazing partner with us, and blessedly, because they were helping us navigate a territory we had never navigated before. So make friends with those folks in your state, folks.
Yeah, I agree. And they've been great to work to work with, but they still have a lot of questions around liability and can you transfer and all of those types of things that that have to be worked through, I think, over time. And there is a lot of national work that's going on that I think will continue to help with that. One of the best things I still think that can be done is to really promote 988 and for it to become call 988 first if it's a mental health and addiction issue. And then if law enforcement needs to be pulled in, that can happen. But let us work through what we can do from that perspective.
Agreed.
Carrie, there were a couple other questions on the transportation initiative. One was asking, is there a code or any stuff from the legislature that other states could look at in terms of your law? And second question, if someone needs transport to a higher level of care, you mentioned there were options or rules to transport to the nearest service, but the question was, is there a room for consumer choice?
There is, yeah, there's definitely room for consumer choice. But for the most part, this is not, I've been inpatient for 3 days and I'd like to be transferred here. This is really more at the emergency point of getting someone appropriate care and treatment. And yes, Senate Bill 7, no, that was on the tablets. I'd have to pull up. There was a bill the previous legislative session and one this last legislative session, and I can get that to Ted or to NASHBID to get to you so you can look at those laws that were passed. And when we initially did it, we put a fiscal note to the bill to move forward, and we used it based upon law enforcement would turn into us mileage reimbursement. So we thought we had a good handle on how much law enforcement was transporting. What we found during the first year is a huge woodwork effect of people who were probably needing to get to care and needing to get to evaluations, but weren't. And oftentimes because of that transport barrier. So we saw a big woodwork effect. And then we went back to the legislature the next year with our actuals, and then they continued that funding from there and increased the funding. But yes, I'll get that to Ted. I might try to look it up as we continue to talk, but I don't know that I can get that for you that quickly.
Okay. Both of your states have mentioned a lot of support from your legislature, from law enforcement, and everybody for working on the crisis continuum. What data information is most helpful for them to make the case to support you, or for you to make the case to them? What is it they want to see from your crisis system, and how do you get that data to them?
I'll let y'all go first if you like.
Yeah, I can jump in here if you'd like. So in Georgia, we've got really good, strong relationships with our local sheriffs as well as our sheriff's association. And we take every opportunity we can get to go and speak at their conferences, as well as to meet individually with them in the different counties. Some of the information that's really interesting for them is around some of the diversion type things that we can do. For example, one of the data points that we frequently share is the number of active rescue calls that come to us, or the number of calls that come to us versus the number of active rescue calls that we send to them. We are about 1% to 2%, which is about the national average. And so it helps our law enforcement understand that, first of all, not every call into 988 or GCAL goes to them. And it's only those that are most in need or where somebody is very imminently in danger. More recently, we've found another piece of data that they find very interesting as well. And it's around our mobile crisis teams, because there are some situations, again, where either the call comes into the call center and it's appropriate for a mobile team to go, but they might go in tandem with law enforcement or have law enforcement kind of aware that they're going. But again, it's a very small percentage. And some of the feedback that we've gotten from law enforcement is that they only know what they see from their calls, right? And they don't know what's happening behind the scenes with our mobile teams and the call centers. And that perspective alone has helped us a great deal in building trust, in building those relationships, and really showing the efficacy of those services. So Wendy, again, I'll pause and see if you have anything else to add.
I'll just add that we launched the first year and a half with weekly meetings with 911 representatives and the association and their association. And then we finally moved to every 2 weeks, and now we've moved to quarterly, but we were knee deep with them at the onset. So I think the relationship piece is crucial. Dawn is spending a tremendous amount of time in front of the sheriffs at their quarterly events, and is quite brave in doing so, I will say. And I put in the chat our 988georgia.org website, and we have our data dashboards live on there. And so you can look at those numbers that Dawn was talking about, the active rescue data, the number of mobile crisis dispatches, the numbers of calls. You can look at it over a week. You can look at it over 5 years. You can do all kinds of manipulation of that information. And that also, I think, has tremendously helped because it builds transparency. It builds trust between us when there's spikes. Folks can look at it when they experience something in a certain area. They can know whether or not that's an anomaly or not. And so we have a lot of traffic now going to that site. And quite honestly, it's helped because we were getting so many data requests. So I think that question is great. And I think really some of that data transparency is so crucial to building these relationships of trust with folks.
And I would agree in that having strategic partners who also benefit from the investments from legislature really help, and that can advocate for you. And in our state, our Sheriff's Association has been really great. Our police association's been really great, our district attorneys. But also, you know, there's a large group of our legislators that are from rural communities, and they know the challenges that rural communities face, and they understand that investment in this system can have a big impact on their communities. And so it hasn't been hard to get investment around these continuums. And then in terms of both transportation and the technology piece. So technology piece with law enforcement having tablets, we did that as an initial pilot and kept data around it, including survey data from law enforcement. And then it was very easy to get that in all law enforcement vehicles. They kept track, and we kept track of the decrease in miles they were traveling, what that saved their counties dollar-wise through the pilot. And so then to get statewide funding became a pretty easy lift. So the data has really helped us over time, both where we can show reduction in hospitalizations, reductions in transports out of the community. We also show things, so when we do say on the children's crisis continuum, we can show where kids are staying connected to their families and not moving into foster care. All those types of things that most state representatives and senators, that is important to them, we can demonstrate how that improves that care and those outcomes around their citizens and their communities.
And I do want to just represent the link that Carrie was just making, and it's so critical, is that those relationships do tend to convert to investment, interest, investment, and therefore then us continuing to grow the infrastructure of the 988 continuum. And again, we received 24 million. I put that in the chat this past year. Still not enough, but we have we have financial barometers that we have in the state, and like we show every time money comes in, we show the barometer amount, you know, changing like a capital fundraising campaign, and we try to just keep showing those for consistency to show why we're asking, make it very clear about how far we have to go if we move towards the projected impact that everyone is talking about us having over the course of the next few years as the marketing campaign really actualizes. And so I think laying all of that transparent foundation is very critical. And I think it does slowly build that trust and build the willingness to invest.
And I would say one of the things I think that has really helped us too is by having a state system that is a statewide CCBHC system and leveraging that for our crisis continuum of care. We received, for example, $7.5 million to grow urgent recovery centers and crisis units. Well, what I can show the legislature is I use that for startup money. And then those CCBHCs are able then to put that staff and programs into their cost report, and then I can reinvest those dollars and open more urgent recovery centers and crisis units. So I can make their dollar go so far under the CCBHC system when folks are able to then put those programs into their cost reports to carry on, and then I'm just paying the match for that in the long run. So it's a really good investment, and I'm able to articulate to them why this is a good investment and how much return they're going to get on each one of these dollars.
We're getting there too, Commissioner. we're slowly making our way that way as well. And I think we're enjoying. I'm enjoying just talking to Oklahoma about this. We're going back and forth. We have a state plan amendment sitting in CMS's hands right now. So we hope to be going the way of Oklahoma on some of those investments in the future. And we are also keeping some of our crisis infrastructure separate.
Yes.
And that's how different states will handle this based on our histories and our current cultural context. So, but a lot of community-based work, we are going to be moving into CCBHCs.
Now, both of you have talked about how useful and important it is to be able to move the data between systems and use it to demonstrate. We often hear, though, we're trying to fund a program to get it up and running. We don't have money to pay for the IT, all this extra infrastructure for measuring. How much did it cost to have this this data sharing, the IT to monitor what's going on? And, did you build it yourselves? Are you buying it? What's your advice to a state that's just rolling out mobile crisis receiving and trying to figure out how do you best have a system to monitor how well it's working?
Well, I would say the way Oklahoma does it, I don't think you can get any more of a shoestring budget than we have had through the years. And we ourselves have built a comprehensive data platform behind the scenes in which we collect data around everything that we do. Now, all of our provider system and network are used to entering data into this, and we work with their EHRs to make it easy and seamless for them to submit data. And then we feed that data back out, and we do it in a lot of different ways. Mostly folks have a login into our system that's unique to them. They can come in and see reports unique to them. They can see for anyone who is discharging into their area, say from a hospital or a crisis unit, they can go in and see data unique to their system and how it links to them. But most of that has all been built within our system by really hardworking, great IT and data folks that have just continued to update it through the years. So there wasn't ever, I don't know that we've ever received a large investment in IT, to be honest. So it can be done. It has to be strategic, but it can be done.
Yeah, and I could.
I was going to say, I'll talk about the foundation for just 10 or 15 seconds and then kick it to you. Initially, and folks, I think it's important to know that the Georgia Crisis and Access Line, that RFP was let for the first time in 2006. And so we began kind of buying this infrastructure back at that point in time. But now that means that was old technology, right? And it kept having to be updated. And with the ASO purchasing in the way we did, then that was a bid process, and it was a super comprehensive product, as Dawn described. And so a lot of that was cost was rolled into that original framework. Now that was pre-988. And so since then we've had to do a lot of work, and I'll just let Dawn add some additional comments on any of that.
Yeah, sure. So obviously, unlike Oklahoma, we did not build our own system. We contracted with Behavioral Health Link and Carolyn to do that. But the advice I would give to other states is that if you can get kind of a sense of what you want your system to look like, understanding that changes may need to be made along the way. There are, some of the federal grants that are out there for 988 do allow some technology, a piece of it to be technology. And just from a practicality standpoint, it's unlikely you're going to find a firm that can build the whole system at once anyway, because it's a very heavy lift. But to kind of think through what you want it to look like and then work through it little by little as funding becomes available. I know at one point many years ago, we got a TTI grant for a small upgrade that we needed. And so, just look under all the rocks, think about all the pieces of funding that you can get, and then, kind of work towards what ultimately you want your system to look like.
Great. At this point, we're going to turn off the recording and allow states to unmute if you want to ask some questions that aren't on the formal recording. The recording will go up on the SAMHSA's website. This is